Well, here we have a young lady that obviously has a pretty smile, and we're dealing in the aesthetic zone, which just increases the issues of doing any dental treatment on this area. So we're going to atraumatically remove tooth number 7, which again is a failed root canal treated tooth. It had been treated as the other teeth with ceramic crowns. So what we're showing here is we're going in with a periotome after using our intrasulcular incision. The periotome will loosen the tooth, sever the periodontal ligament, and then you're going to see that we can take and bring the tooth out in whole, keeping the buccal plate intact, which is critical for this immediate implant placement. We're going to debride the socket. There is some granulation tissue associated with the appears to be a horizontal fracture of the tooth about halfway up the root. We're going to just find out our socket depth and then plan our implant length and size. Here we're going to be down in the socket about 10 millimeter length of root, and we're going to check the width at the crest, which is about 5 millimeters, and the apical area of the root is only about 3.5 millimeters. Although this may seem to be a 5 millimeter diameter implant placement, that would put too much pressure on the buccal plate of bone and increase our chance of resorption in that area and then failure of the implant. So we're going to place a 4.0 by 13 millimeter implant. We're going to make our osteotomy. It's going to go 3 millimeters below the apex of the socket. This will give excellent primary stability, and then we're also going to fill in the remaining space with a particulate bone grafting material. It'll be a combination of freeze-dried demineralized bone and also mineralized cancellous bone. We're also using PRP, platelet-rich plasma, and this adds all of the growth factors necessary to have excellent healing in a very rapid fashion. It will increase healing so greatly, it's probably 50% faster, if not more. We've already done our blood draw. We've spun down the blood, got our platelet-rich plasma, and we'll mix the bone grafting material with that PRP. Here we're just finishing up the osteotomy, being sure that there's no perforations in the bone. Here we're showing our membrane that's going to go into the area. We're going to place a membrane. This is our freeze-dried demineralized bone, and we're going to mix that with our PRP, or platelet-rich plasma. This gives a very good consistency to any particulate bone grafting. We're also going to just place the PRP into the socket. Amazing rapid healing properties that this gives, all of the growth factors and the cascade of events in leading to the new bone formation. Here we're showing a membrane going into the area because we did have a buccal plate perforation in that area of the root canal failure. We're going to put in our PRP and bone grafting mixture. We want to place our probe all the way down to the end of the osteotomy to be sure that it area is patent and that the implant is not held up by obturating that osteotomy. Here's our implant. We're using a Nobel Biocare. This is a tapered groovy implant. We're coating it with PRP. And then we're going to insert this. Now, what we're looking for is torquing this to 35 Newton centimeters. As long as we can get 35 Newton centimeters of torque to stabilize the implant, I can add a temporary abutment to this and place a temporary crown. Now, if this doesn't torque to 35 Newton centimeters, then we have already prepared a removable Essex type appliance which the patient would use in the interim healing period. Now we're finding here that unfortunately the stability is only to 20 Newton centimeters, so we are going to place a healing abutment. We want to not use a healing cover screw because we don't want to have the papillas blunted during the healing. So I'm going to use a healing abutment. This is going to give support to the papillas. Then we're going to suture or close the papilla area using a vertical mattress suture. This is a papilla sparing suturing closing technique. This will heal very nicely, and then we're going to place the Essex appliance, which is essentially a mouth guard with the missing tooth added in acrylic. Here we're showing the Essex appliance, which has been prepared ahead of time just in case it's needed as a fallback. We weren't able to place the temporary abutment. Here we're showing the suturing technique using the papilla saving closure. This is a vertical type mattress suture that causes the eversion of papilla so that it doesn't contract and blunt on healing. We're using a 4-0 suture. Actually, this is a 5-0 suture. And here we have the papilla back in place, and what we've accomplished is we've atraumatically removed the tooth, we've placed an implant, we've got it stabilized to 20 Newton centimeters, which is fine. It will heal very nicely. It's just that we can't use a temporary, even though this temporary wouldn't be directly loaded. The fact is that we don't want any pressure on this implant. We've used a healing abutment on the implants to maintain a soft tissue contour, closed it with a papilla saving suturing technique. Here you see what is commonly called platelet poor plasma. We add thrombin to the platelet poor plasma. This is actually fibrin-rich plasma, which would be a better term, and it acts as a wonderful band-aid to cover the site, promotes excellent healing. The healing went uneventfully with this patient, and we waited for 2 months to load this. We took final impressions and had a custom Procera ceramic abutment made and a ceramic or zirconia Procera crown, and these were seated, and the patient's very happy, the implant's stable, the tissue's healthy.